Hi, our drug is phenytoin, an anti-seizure medication. Its therapeutic classification is an antiarrhythmic and anticonvulsant. Its pharmacologic classification is a phenytoin. Its mechanism of action is that it limits seizure propagation or movement by altering ion transport. It also shortens the action potential and decreases automaticity as an antiarrhythmic. Its indications for use are treatment prevention of grand mal seizures and complex partial seizures. The side effects are suicidal thoughts, ataxia, agranulocytosis, aplastic anemia, Stevens-Johnson syndrome, and gingival hyperplasia. The patient teaching is that it take medications as directed at the same time each day. Take missed doses as soon as possible, but do not double doses. Avoid alcohol and CNS depressants. Instruct patient on importance of maintaining good dental hygiene. May cause drowsiness or dizziness. Advise not to take phenytoin within 2 to 3 hours of antacids. And instruct patients that behavioral changes, skin rash, sore throat, mouth ulcers, easy bruising, petechia, unusual bleeding, abdominal pain, chills, pale stools, dark urine, jaundice, severe nausea, vomiting, drowsiness, slurred speech, and unsteady gait should be reported to healthcare professional immediately. Nursing implications are monitor closely for notable changes in behavior that could indicate suicidal thoughts, behavior, or depression. Assess oral hygiene. Assess patient for phenytoin hypersensitivity syndrome. Observe patient for development of rash. Discontinue at the first sign of skin reactions. Assess mental status before and periodically during therapy. Assess seizure activity. Monitor blood pressure, ECG, and respiratory function during administration. And monitor CBC, serum calcium, albumin, and hepatic function tests prior to and monthly. And then this is our test question. I'll let you read. And then we have a YouTube video of how this medication works and some other seizure medications.
Seizures are the clinical manifestation of a hyperexcitable neuronal network driven by the flux of ions across the cell membrane, actions of glutamate, or inadequate inhibition by gamma-aminobutyric acid, or GABA. Available anti-epileptic drugs, or AEDs, generally act to enhance inhibitory processes or oppose excitatory processes. AEDs affect numerous molecular targets, and some act on multiple targets to help control seizures. Many of the available AEDs block sodium channels. Voltage-gated sodium channels enter an inactive state following each action potential. Prolongation of this inactive state prevents neurons from firing rapidly and is thought to be the principal mechanism of AEDs such as phenytoin, carbamazepine, and lamotrigine. A potassium channel opener enhances transmembrane potassium currents by keeping these channels open longer. This is believed to stabilize the resting membrane potential and reduce brain excitability. Calcium channels also represent AED targets. Low-voltage calcium currents cause rhythmic spike and wave patterns of generalized absence seizures. Some AEDs block these channels, inhibiting slow depolarizations necessary to generate spike wave bursts. Blocking high voltage calcium channels inhibits neurotransmitter release. Here, one AED binds to the synaptic vesicle protein, SV2A. Binding at this site may modulate synaptic transmission through alteration of vesicle fusion. GABA is an inhibitory neurotransmitter, and the GABA receptor is part of a chloride channel complex. Mechanisms enhancing GABA-mediated inhibition are believed to include receptor agonists, prevention of the breakdown of GABA by inhibition of GABA transaminase, and decrease of reuptake of GABA. Both valproate and topiramate act through multiple targets, such as enhancing GABA, inhibiting glutamate, or altering the generation of action potentials. By knowing the differences in MOA among AEDs, in particular their effect on neuronal activity, we can begin to more fully understand the impact it can have on effective seizure control.